programs of endoscopic ear surgery in developing countries need a different perspective, unlike those of developed ones. Thank you for your attention. Now, let us start with our high-profile African guests in alphabetical order. The first speaker is Dr. Chimmy Olende from Kenya. Dr. Olende is a consultant of otorhinolaryngology in Nairobi, and she moderated many cadaveric dissection courses on endoscopic ear surgery. Dr. Olende's presentation entitled Tips on Beginning Endoscopic Ear Surgery. Dr. Olende, welcome. Dr. Olende.
Thank you very much, Dr. Walid.
You have 15 minutes, Dr. Olende. And welcome virtually again.
Dr. Walid, you can hear me?
Yes, I can hear you. Yes.
There is echo, Dr. Walid.
But there's some sort of echo, yes. Please, you can...
There's an echo.
I think
yes.
You are using two devices, two audio devices. Don't please disconnect one of them.
Hello?
Hello? Yes, but there is some sort of echo, Dr. You have two devices, Dr. Olende.
Can you hear me now? It's too loud.
If you open two devices, please turn off one of them.
I want to turn it off. Yeah, because it's echoing.
علاء ابدأ الأول البرزنتيشن.
Hello?
Okay, it's audible, but there's an echo.
Can I start now?
Yes, it's better then.
Okay.
But there's some sort of echo. When we start the meeting, your sound was very clear. When we start the meeting, the sound was very clear. So you can turn to the same technique you used. Dr. Olende, you are with us? علاء. علاء.
ايه دكتور محرك فن؟
دكتور أولندي معنا؟
تقريبا هي خرجت.
طيب ممكن نبدأ ننسق معاها ونخلينا مع دكتور استي ماير لحد ما الدكتور أولندي يكون.
تمام يا دكتور.
دكتور أولندي. طيب يعني متهيألي إنها بتغير المكان. طيب خلاص يبقى احنا ممكن نستارت مع دكتور استي ماير. دكتور استي ماير, is you here? Dr.
Yes, I am. Do you want the pre-recorded talk, or do you want me to go live?
Yes, you can go live. You can present your presentation live. May I introduce you first, please? The next speaker, tell Dr. Olende is coming. Dr. Estie Meyer from South Africa. Dr. Meyer is a consultant of otorhinolaryngology in Groote Hospital, Cape Town University. Dr. Meyer was interested in practicing and teaching endoscopic ear surgery for more than 10 years. So I think Dr. Meyer's presentation entitled Teaching Trainees Endoscopic Ear Surgery. my 10 years experience. Dr. Meyer, welcome, and you have 15 minutes.
Sure, thank you very much. It's a great honor to present, and it's a pity we can't see one another live. So Groote Schuur Hospital, as you know, that is Table Mountain, and it's only from one angle that it does look like a mountain. So if you just go across the mountain.
Please, Dr. Meyer, may you share the screen, please?
Let's just see.
Share the screen, share screen.
Can you see it now?
Doctor, I can share her video. If there is any problem, I can share it. We cannot see your presentation, Doctor. Can you share it again, please?
So I'm sharing it. It might be because you're not showing the pre-recorded talk.
I will share it now. Thank you.
Okay. Good evening. I am Estie Meyer. I am one of the otologists at Groote Schuur Hospital in Cape Town. And it's a great honor to be talking to you at your wonderful meeting tonight. Now, Groote Schuur Hospital is just at the foot of Table Mountain. As you can see, there's Table Mountain. It only looks like a table from a certain view. And just as you cross the mountain, you're going to get my hospital. As you know, of course, that's where the first heart transplant was done. Now, I've been doing endoscopic ear surgery for about 8 years. And because Groote Schuur is a teaching hospital, I have been teaching it for more or less 7 years. There's lots of articles on learning curves, especially if you are used to a microscope. And of course, the advantages of an endoscope over a microscope. But there's not a lot of training future endoscopists. So I find this article from Dr. Patel from Sydney very useful. And then just in this year, February this year, there was another article published on teaching endoscopic ear surgery. So we do run courses every year where we teach very seasoned otologists how to use the endoscope as well. But this talk is going to focus especially on my experience with teaching trainees, or how we call them in South Africa, registrars. Now, it is not difficult for them to master the endoscope. They're all used to using the scope in noses in the clinic. I mean, they use it every day. If you think about it, the ear canal is pretty narrow channel. So it's not as tricky as the nose with different directions you can go into. And face it, once you are through the annulus, the bleeding stops. So the trick is just to teach them how to get through the annulus. At my hospital, the entry exam for ENT candidates is what we call the intermediate. So by then they should have done a year of surgery, which means to say the hand-eye coordination is established by then. Now, this is not a debate of the endoscope versus the microscope. Both skills are necessary and one never really replaces the other. And I am now a much better microscope user now that I have used the endoscope so much. So 3 things I want to discuss: when in training you should do it, who must teach them, and what I call the hidden tricks. Now, we are 2 otologists in my unit. It's me, and then there is Dr. Harris, who did a fellowship in Switzerland. So she's a skull-based surgeon. She is amazing with a microscope and a drill. But she is not good at teaching endoscopic ear surgery, because often you need to know at which canal you must advance the instruments. Often it's a simple case of just changing the instruments around. And because she is so impatient and because she just drills and widens the canal, she's not good with the finer tricks of how to get to a difficult corner. She gets very frustrated if it bleeds because she can't use a suction. In the beginning, a lot of patience is necessary. And if you are very good with a microscope, she finds this too long and too tedious. So all I'm saying is she's brilliant with a microscope and drilling, but when it comes to teaching the endoscope, she is not the best person for the job. So in our hospital, we clearly divide the cases as purely endoscopic cases versus where you would need a microscope. So we would base this on clinical judgment and imaging. So the pros of this is that the trainees get taught by the best person for that modality. So if it's a straight endoscopic case like a dichotomy, I would be doing it. The bad thing about it is I would probably persevere much too long and go from an dichotomy to a mastoidectomy with just a curette, where sometimes it doesn't make sense and you should have just converted to drilling. So that's the one bad thing. But I do think in this approach, the best person for the job teaches the registrars how to do it the best way. Now, I always joke, and I always, in the time when I just did microscopic ear surgery, I said, if the consultant ever asks you what a structure is, the answer is always the facial nerve, if you can see it or not. And this is the beauty of the endoscope. You don't have to guess what structures are anymore. So when to train them? Now, the advantage of the endoscope is the anatomy is easier to see than with a microscope. Only the surgeon has depth perception with a microscope, and you can only see a percentage of the middle ear or the mastoid cavity or the tympanic membrane. So how many times has it not been that you've been off the screen and you had to say, just get up, I just want to see where you are. So for beginners to understand tricky anatomy, like terms like sinus tympani and facial recess, the endoscope is the best because it's not foreign concepts, these anatomical structures anymore. We can show it to them. And it's also easier to supervise them because you can see a 360-degree view of what they are doing. But it is tricky in the beginning to only use one hand. And it takes a while to learn how to manipulate the tissue, how to retract it, if you must push the tissue, whether it's a pulling action necessary. And it is difficult to control the bleeding in a narrow canal if you start. So what we do at our training facility is we teach them both at the same time. So we don't say you need a year of microscopic in otology and then you can use the endoscope. From the start, they get exposed to both modalities. And often we have this gossip session in the changing room, and we have found that if you are not good with an endoscope, you are also not good with a microscope. So it's not as if you are good with the one, but we need to get you better with the other. You often are not good with both because it's one of those things it's a hand-eye coordination, or you're just not good with your hands, and we need to train that ability a bit. Now, I always joke and ask the registrars, can you do needlework? And it's actually my way of saying is you need hand-eye coordination to improve a little bit. Now, of course, everybody plays video games, so the concept of doing needlework is a bit foreign to them, but that's my little tongue-in-the-cheek way of saying we need to practice this a bit. Now, if you look at Dr. Patel's article, the Sydney chart, they do it very much stepwise, like you've got to do this, and once you can do this, you progress in certain steps. I always thought in South Africa and in Africa, we just get on with it. So normally I would let them start harvesting a graft. Then they get to freshen the edges. Then they can raise the flap, the annulus, and get into the middle ear. And of course, the final step in tympanoplasty would be placing the graft. I will probably always take over when particular chain work is necessary, because stability with one hand is tricky. So they would only be doing that in their 4th year. And with us, the ENT training is 4 years. Now, this is one of the first videos that I took, and I did this. So as you can see, I didn't prepare the canal. I didn't cut the hair. The camera is way too far from where I want to cut. And I'm probably resting my curved needle too much on the canal, causing some bleeding, which then I have to control. But grommets is one of the best ways for them just to get that feel of how deep to go, how to control the bleeding. So always let the registrar start with grommets. And butterfly push-throughs is another good way for them just to get a feel of the tissue. Now, one thing they struggle with is the angles of putting the camera and getting that right. Of course, it's curating, especially the left ear superiorly. It is often, if you've got a total perf and there's anterior work that needs to be done. I'm not sure if you want to see the rest of the talk or whether we can just conclude. How do you want to do it?
You can continue, Dr. Estie. You can continue.
What do I so just play the talk from there. There we go. That's what we struggle with. You can start there. Most with.
Yes.
Number one is handling the bleeding in the beginning. They don't know when to suck, when to clean, when to wait a little bit. That is something that needs to be taught. I find that they sometimes clean the scope at inappropriate times. Like they would have a beautiful view and like in nose surgery, they would go and clean it. Or they can't see and then they want to persevere. Now, unfolding a crumpled up fascia flap is how I know whether this registrar is going to be a good otologist or not, whether they have the patience to try and see if they can unfold this mess that suddenly is the beautiful fascia that they harvested. Like I said, angling the instruments and knowing if you struggle how to adjust it, or sometimes just turn it like 180 degrees might make it easier for you. And then there's the things that they don't know I'm doing because they're busy flirting with their anesthetist or scrubbing because they're so eager. And those I call the missing steps. Other things they struggle with is resting the scope or the instruments on the canal. So you get that bit of bleeding that you then have to control. I find that if they've, like in a total perforation, got to raise the flap anteriorly, they struggle with that action of 180 degrees, turning your instrument around. And it is a tricky angle. Of course, even for me, left ears, superior attic wall is difficult to correct. They, of course, all struggle with that stab technique in the beginning to get maximum bone. They kind of more want to do a scoop ice cream action where they remove little bits of bone, where with an endoscope, if you want to get on with it, I don't use a drill because I cannot break the scope because we don't have money to replace it very easily. I put it more behind the wall and then I can remove bigger pieces of bone. And then placing the cartridge with one hand takes some practice. In the beginning, they often make the graft too big, and it is a problem unfolding it if it is too big. And they must also know which cases are good with only the endoscope, and they must learn to know when they would use both modalities. And often they forget to look at the ear canal. I only have a 4mm scope, and sometimes they put very narrow ear canals, and those are just tricky to do, especially if you want to be taught by the case. So I always tell them to custom make the list so that they learn what they still feel they need to practice. And if they book a patient with a narrow canal, it's just very tricky for them to do. Now, then there are the secret steps that they never see me do. The one is very effective infiltration of local. So I do basically a 360-degree injection. I do put a Tarabici stitch in very often, or I would halve a tragus cartilage while the nurse is still unpacking a tray, and then put the stitch in the tragus there, just to straighten the canal a bit. They often forget to trim the ear canal hair, and I use quite a big size cotton wool ball, sometimes with adrenaline, sometimes dry, but it's not a small ball. It basically fits the whole ear canal width. Now, endoscopic ear surgery differs from microscopic surgery with very small things, and that is something that takes time for them to learn. Now, the one is the tympanomeatal flap can be longer. It doesn't get in your way. I find cartilage is much easier to use with one hand with fascia, but when I use a microscope, I will probably use fascia. Now, often with a post-auricular cut, it's very easy to harvest the fascia, but if they just want fascia, they sometimes struggle with that small 1 centimeter cut to get into the right plane. Now, whenever I ask them, how would you raise the flap for a perforation, they always say from 6 to 12 o'clock. And the beauty of an endoscope is you can tailor make it to where your perforation is. So you don't have to do it from 6 to 12. You can literally look at your perforation and say, I only need to raise it there. So that is sometimes there's something they need to learn, because with an endoscope, you can have a beautiful view anteriorly that you don't have with a microscope. Now, the debate of should we teach them with endoscopic ear instruments? I don't think so, because in the beginning, bleeding is a big problem, and I do think they need to learn how to stop it without suction instruments. What I find with an endoscope, and that I never knew with a microscope, is that often if you pull tissues in the right way, you can get to a certain place much quicker. So I invested in very fine cupped forceps from the beginning. And that is something that you can do with normal instruments. You do not need endoscopic ear instruments. And I think the best benefit of endoscopic ear instruments is if you don't use the normal instruments often, you don't know why endoscopic ear instruments are so beautiful, why it's angled a certain way, why it's a certain length, and how it makes your life easier if you do not struggle first. So I do not let them play with an endoscopic ear instrument, probably until their 4th year. The other thing is they are a bit more heavy on the hand. So you need to be quite slick with a normal instrument before you now get this added extra dynamics to the instruments. So in our hospital, the trainees only have the non-suction, old-fashioned otology instruments. So when would I take over from the registrar? If they cannot control the bleeding, and before they get so impatient and lose all hope. If they tear the annulus and I don't know how I'm going to fix this perforation, that's more in total perforations. And the moment there's ossicular chain work necessary, I would probably take over, unless they are 4th year and they have proven that they've done the work and they've got that hand-eye depth coordination. Now, very important, it needs to be an HD screen. Otherwise, the moment there's bleeding, it gets distorted. Now, why I say this, especially in Africa, there have been amazing gadgets made to have Apple Macs. They can do laryngoplasties on them. But I think if you want to teach, and if you want to teach middle ear pathology, it's best to have an HD screen, because the moment bleeding comes into it, the beauty and the benefit of endoscopic ear surgery, you cannot see it if there is bleeding and if it's not an HD screen. And very important, plan your lists. If you're going to teach, you need to add more time. So often we put TIMS and grommets as the fillers just to make sure we use the whole list. But then they can't learn, because you literally need to sit behind them, have lots of patience, and take them through step by step. So you have to custom make your list a little bit when teaching, because you have to allow for them to struggle. Now in COVID, for a long time, we couldn't operate. And the simple reason was nursing staff was a problem, but we didn't have anesthetists because they were all kept busy in ICUs. So we started doing ears under local. Dr. Wagner from America had this nice protocol, and we thought, okay, let's try this. And we didn't use conscious sedation. In the beginning, we had a few complications. We had temporary facial nerve palsies. They vomited on the table, but now it's quite doable, and we got the recipe, and it's quite easy to do. And you can teach because the block lasts long enough so that you can have a good teaching session. The only funny thing is, I was once teaching, and then the patient asked, "Doctor, can't you just please take over?" So if you've got conscious sedation, absolutely much better, but it is doable to teach endoscopic ear surgery under local, and everybody can benefit from it. Now, at the second endoscopic ear conference in Bologna, there was a consultant from Canada that said, remember always to end things in a good way. So even after I've criticized my registrars, I try when I take over to end it by saying something good that they did that day. And thank you so much for this amazing privilege to talk at your course. I hope you all stay safe, and that hopefully we can travel soon. Now, this is a very old-fashioned photo of Grote Schuur, but this is just to show you the most beautiful view we have of Table Mountain. And as you know, this is where the heart transplant was done, but I just cut out the modern building on the left where most of the operating gets done now. Have a great course for the rest of the evening. Thank you.
Deep thanks, Dr. Meyer, for the amazing and the presentation and your valuable presentation indeed. Deep thanks for the presence with us. The next speaker is my dear professor, Dr. Hassan Chelly from Morocco. Professor Chelly is a professor of otorhinolaryngology in Casablanca, and he is one of the eminent African members of the International Working Group in Endoscopic Ear Surgery. Professor Chelly's presentation entitled Improving the Results of Endoscopic Ear Surgery. Professor Chelly with us? Professor Chelly?
Yes, I am with you.
Welcome, welcome, Dr. Chelly.
Thank you very much.
You have 15 minutes, and all of us who are waiting for the amazing presentation.
Thank you.
Nice to meet you, Dr. Hassan.
Yeah,
I'm very happy to see
you. Thank you, Mohammed. Thank you. I'm so glad to participate to your invitation for your wonderful and tremendous work about.
Yeah, but this is not ours. This is yours now. This is Pan-African. So it's,
no problem. No problem. I'm really glad to join you on your work and your reflection about endoscopic ear surgery. You know, I started after a long while exploring microscope with Professor Cerca's team in otology and school-based surgery in Paris. And after 6 years, from 6 years to now, I exclusively start to work only on endoscopic surgery. And I try to share my screen. Here it is. So the reflection is when we are learning and when we are hearing pioneers speaking about endoscopic ear surgery, the comparison between microscope and endoscope is really a comment. I think endoscopic is a new era of surgery, and I'm trying to, by this talk, to achieve a reflection, to talk about really improving results in endoscopic ear surgery. Now the balance comparison, I think it was told by the previous speakers, it's to forget. You have to forget this point. Microscope and endoscope is a tool for achieving ear surgery, and I think the aim of audiologic surgery is to run it safely and to reach our goal. Is run and reach. So 3 points in my talk. The first one is about our experience. The second, learning curve for skills procedures, and finally, how to develop performance in endoscopic ear surgery. My experience, when we compare the two, for the same case here, in the case of otosclerosis, you see that the pictures and the view is wider, and you have a better structures exposition. You see my presentation? You see my screen or not?
Yes, but can you get the second? I see the disclosure, only the slide with the disclosure.
Ah, yeah. Now?
No.
I think the projection is late, according to my presentation. Now you see.
No, only the slide with the disclosure, Hassan.
Yeah.
In which no conflict of interest, the disclosure. This is the only slide we have.
I will maybe.
Can you make it live from your computer?
Yeah, it's from my computer.
Oh,
yeah,
okay. Maybe stop sharing and share again.
Yeah, I will try this. Good.
No, you didn't share.
I share again.
Can I try again, please, sir?
Yeah. Mohammed, you see it or not?
No.
Still not, sir.
No?
Not yet.
Not yet.
هلا احنا ريكوردنج المحاضرة بتاعت الدكتور حسن؟
I don't know what's happened.
Yeah, yes.
You see it now?
Yes, balance comparison.
Yeah,
yes.
good.
Yes.
Good. I was talking about the aim of pathologic surgery is really to run it safely and to reach our goal. And 3 points for my talk. The first one is sharing my experience about so many cases from 2016, learning curve for skill procedure and how to achieve performance in endoscopic ES surgery. When we, you see the presentation, Mohammed, is good?
Yes, yes,
Good.
yes.
When you see this comparison between the view, the field, in the same case from otosclerosis, you are here, and on the left the microscope, and on the right the endoscope. I think the view is wider, and the structures are better exposed. No talk for that. The reflection is if you achieve the procedure from the microscope, the same technique using the endoscope, I think it's not necessary, because you have 2 hands and 3D in microscope, and the ES is one-handed surgery, and you lose the depth of the field. So it's certainly better to you have some difficulties, but the reflection is sensorily is minimal invasive, leads to improved results, maybe by describing a new surgical procedure and tips to achieve, improve the results. The question is, endoscope, it is a tool like a microscope to achieve a procedure, or really a concept? Really a concept? I think it's a concept, because you have many possibilities offered you by the endoscope. We'll see my activity is running from 2016. From now, exclusively endoscopic ES surgery, more than 700 cases. And the cases are like that. Most of them tympanoplasty. After that, otosclerosis, retraction pocket, and cholesteatoma, exclusively surgery. When you will talk about that years later, everybody love, because achieving cholesteatoma without drilling, without opening the mastoid, it's really a difficulty. Acquisition skills, you see the steps for achieving surgery from external auditory canal to internal auditory canal, and you see we have an expression: who can do more can do less. If you achieving surgery of skull base and the internal auditory canal, like acoustic neuroma, you still do with no problem surgery of the middle ear. The beginning is really difficult for those who come from the microscope, but the trainees who had underwent sinus surgery, it's a better field to enjoy the endoscopic surgery. You see the learning curve. The learning curve is difficult, well, so you have to be efficient in endoscopic surgery, and you have 3 areas. The areas, first one, you have difficulties because you talk and it's hard. The second one, I've got this, it's fun because you are progressing, you're achieving, you're enjoying. And the third step is the last one, who the improving is late. It's hard to improve because you have a kind of stability. Modern application, you have a learning endoscopic ear surgery at every steps. On residency, ear established surgeon and microscope surgeon, you see that you have not experienced in a residency, you have a low cognitive bias, and sure, you have on hands-on endoscopic cadaveric dissection, and you have so much courses about microscope dissection. So, ear established surgeon, you see that he had a middle ear surgical experience. So when you are visiting another endoscopic ear surgeon, you can see all the tips, all the pitfalls, and all the difficulties, and you can, and that's why when you are so experienced in middle ear surgery, it's not hard to move from microscope to endoscope surgery. So you have to make the first choice. It's important to the first choice. Excuse me. I'm just trying to move from the field. Good. The first choice, the first patient, you have to you have to move from your comfort zone, because when you are achieving and you are a microscopic surgeon, an ear surgeon, you move from two-hand to one-handed surgery. You have sure to choose your first case, and you have the instrument to help you for that. And Dr. Walid talk about Panetiset. I think it's a really amazing tool for endoscopic surgery. And now even the teaching way in otology has progressed, because later maybe on the first decade of the years 2000, the teaching ways in otology worldwide are always also microscope dissection courses. You have to learn retroocular approach, mastoid cavity, how to make a tympanic cavity. So the dissection training courses are worldwide. So under microscope, and you can ask if you had some ear dissections only endoscopic. So you see the years 2018, you have dissection courses, and one day is only about endoscopic ear surgery. There's progress even in the teaching way in otology, because it's changing from microscope to endoscopic dissection courses. And you see here in Paris with my friend Livio, and here myself in China, in Shanghai, last December 2018, performing a live endoscopic cadaver dissection. So performance, how it comes. Performance is understood as achievement of the surgeon in relation with its goal. It includes outcomes achieved or accomplished through a strategic goal. You see here, for example, a tympanoplasty. In this tympanoplasty, you have a central or inferior perforation, caution to the anatomic failure. So the technique, the tip is to leave the anterior part of the remnant, not to elevate it, because you can have a blunting, you can have also, and the tips is concerning a pillar. You can make a pillar from a piece of cartilage harvested from the tragus, and here you make this pillar on the sulcus, under the sulcus, and after that you give a part or piece of cartilage, and the pillar is here to support the piece of cartilage to prevent falling down. You see here, it's blocked, good, and for falling, this piece of cartilage can fall down in the middle ear. Here is an otosclerosis surgery right here, and you see, I think the best way for right ear in otosclerosis is to use fish procedure. Fish procedure, you recline, elevate the chordae tympani. After that, you make a Rosenauge and exposing the oval window. You have after that to measure the heft, the depth of your surgical field, to make your platinotomy, and after that you have in place your piston, and so you have, after that you have a tenotomy, capsulotomy, to leave the stability of the system. I think it's for the right ear. It's I think in my opinion, it's the best procedure to achieve in otosclerosis. Here in otosclerosis, here you see difficulty because the facial nerve, you can see it, is uncovered in his second part, and you have a small piece of oval window to check, and so you can endoscopically achieve your surgery without damaging the facial nerve. I think the wider view offered by endoscopic is here helpful. Here is a retraction pocket. You see it's a large retraction pocket involving the attic, and you can imagine here by your examination that the facial nerve is uncovered. So it is. You can inspect that surgically with elevating your flap, and so with a cotton ball you can here elevate your retraction pocket, the epiderm, the remnant of the tympanic membrane, and after that you will work with an angled optic, 30-degree. You have here visibility of the dura. It's a tegmen tympani enclosure. After that, you can put a large piece of cartilage to insert. So after, you can see the results of the facial nerve is really good. Even the cochlear implantation, you can assist the endoscopic insertion. You see here you have to drill your round windows, and you are passing through your round window to help to insert your electrode. And this view is really confident, and you have the insertion really better view from the microscope. So every grid movement must experience 3 stages. The first is ridiculous. When you talk to ear surgeon and you tell to them, I exclusively achieve ear surgery using the endoscope, the first reflection is ridiculous. After that, when time changed, time passed, you can discuss. And the third experience, the third movement is the adoption. I think worldwide now, ear surgery has endoscopic adapt. So what's new in otologic field? Research and development leads to develop instruments and so integrate the endoscopic ear surgery in making decision here. From, for example, for instance, you have an algorithm for cholesteatoma surgery using endoscopic ear surgery. After that, I think for those who can really have to move from microscope, I think great things never come from comfort zone. You have to leave your comfort zone to achieve endoscopic ear surgery. In 3 steps, the first question is, I am an otologist, shall I keep or change my habits? So how do I make my learning curve shorter? And I think every time you have to achieve and advance, it takes time. The procedure is long, the learning curve is long, is hard, but be patient, because you see what Herbert Dreyfus, professor of philosophy in Berkeley, said, to become competent, you must feel bad. So I think it's a really interesting. We are what we do repeatedly. Excellence is not an action, but a habit, telling by Aristotle. You see, all surgeries, all reflections are coming from otologists all over the world. And I think that we have to great respect and many thanks for involving all over the world the international working group of endoscopic ear surgery to promote this kind of surgery. And my final slide is about my progression from microscope with all the pioneers from Dubai, from Egypt, from Italy, from Boston, for Brazil, from France, for Japan. And thank you very much for all you have to share with me, to